Hello, friends. Welcome back. We are back again with part two of abnormal uterine bleeding. Uh, it's very exciting stage that we were in yesterday, and today we will continue from where we left yesterday. So we were discussing the provisional diagnosis yesterday. So just for the benefit of people who have joined, can you just recapitulate what was the provisional diagnosis that you were telling yesterday?
Sir,
Yeah.
she's a 51-year-old, para 3 living 3, most likely a case of AUBL or AUB adenomyosis. And as malignancy from her symptoms, because there are no symptoms of postcoital bleeding or intermenstrual bleeding, is ruled out, as well as AUBO is also ruled out because she has regular cycles. And because she does not have any history of any intake of any anticoagulants or any antipsychotics, so even that AOBC iatrogenic is also ruled out.
Asti, you are really clever. I am happy that yesterday's your first diagnosis was slightly different. Today you have changed it, and I'm very happy because yesterday you first told it could be a malignancy, and that we had discussed clearly that since the cycles were regular, it is highly unlikely. It could still be, we don't know. But today you have perfectly listed the diagnosis in that order. So first one is obviously neoplasia, which could be a benign neoplasia, and then of course one by one could be a possibility. And you also give the reasons why you are not thinking of malignancy, why you are not thinking of bleeding disorders. So let us move forward with that in mind. Okay. So before we go any further, okay, we will discuss what are these new classification.
So according to FIGO System 2 classification, we have palm coin classification. And palm, P stands for polyp, A stands for adenomyosis, L stands for leiomyoma, M stands for malignancy or hyperplasia. Then we have coin, in which C stands for coagulopathic disorders, O stands for ovulatory dysfunction, E stands for endometrial causes, I stands for iatrogenic, and N stands for not otherwise specified or not yet classified.
Yeah. So as you can clearly see, the word dysfunctional uterine bleeding is out from this. However, it comes under now ovulatory dysfunction.
Ovulatory dysfunction.
Yes, it could be ovulatory type of problem or anovulatory type of problems. So again, what they have done in this, these are the pictures that what you just now elaborated. There could be any of these kind of problems. They again had a revision in 2018. Can you elaborate on the revision of the same palm coin?
Yes, sir. They have given some sub-classifications. P is that is polyp is yet to be sub-classified. A, they have given a refined sonographic diagnostic criteria, which is according to the Musa criteria, in which A is asymmetrical myometric thickening, B is myometrial cyst, C is hypoechoic islands, D is fan-shaped shadowing, E is echogenic subendothelial lines and buds, F is translesional vascularity, and G is irregular zonal junction, and H is interrupted junctional zone.
Yes, so they have very specifically subclassified adenomyosis, right? So as far as L is
Yes, sir.
concerned, yes.
Sir, they have further given these conditions that inclusion of type 3, FIGO type 3 as a submucous fibroid,
Yeah,
then
earlier only
you can differentiate.
one and two were submucous clearly. One was very well within the cavity, one was partially in the cavity. But type 3, which was almost like,
It's
intramural, but it
intramural
was very close to the cavity. So they have
endometrium.
included them in the submucous variety. Yes.
Then they have given a distinction between type 0 and 1 and 6 and 7 based on the stalk diameter, as
Yes.
well as they
Whether
have
the,
given
yeah.
the distinction between 2 and 3 based on the lowest filling pressures, in which they have told that 2 will cause increased filling pressure and 3 will be less, and 4 and 5 based on the distortion of the serosa.
Yeah, of course. Basically, these things they have made because one thing is when you're treating a case of infertility in a younger patient, right? So the
Yes,
whether the fibroid has to be removed or not is the biggest question. Many a times we say
yes, sir.
submucous fibroids don't bother unless it is in the implantation area, right? So
Yes,
to
sir.
that,
Yes,
whereas one and two, nobody has a doubt. It has to be removed. Again, it depends upon
yes,
how
sir.
much it is projecting into the cavity or not. Whereas a totally type 3 was totally intramural, but it was just kissing the maybe endometrial cavity. However, sometimes that has to be tackled if it is coming in the implantation area. Similarly, 2 and 3, the filling pressure again it makes a difference, huge difference. Suppose let's say the 3 is so big that it is almost encroaching into the cavity, whereas 2 is of course whether it is mostly into the cavity or mostly into the myometrium. Accordingly filling pressure will differ. Again it is basically with regards to infertility and other things. And 4 and 5,
Yes, sir.
they come under the question of if you have decided to do myomectomy, how to do the myomectomy, whether it is, distorting the serosa so much and it is coming closer to the tubes and other things, right? And of
Yes,
course,
sir.
the
Yes,
stalk diameter also important. Sometimes you can catch the stalk and just do the something like a polypectomy. Whereas if it is like a sessile, you may have to incise and do it almost like a myomectomy. So this is the sub classification they have done. An intelligent surgeon needs to know all these things, right? So same thing, I'm putting it
yes,
in a picturized manners for that, for the benefit of people who are watching this. So the sub classification is number one, as we said, the 3 is included as a submucous. As you can see here clearly, 3 is intramural almost, but it is just kissing the cavity. Whereas 0 is with a stalk there hanging in the cavity. 1 is almost in the cavity. 2 is also mostly in the myometrium, but sometimes in the cavity. So 0, 1, 2, there was no doubt, but 3 is now coming under submucous. Similarly, as you correctly said, the 1 and 2 and probably the 0 and 1 and 6 and 7, whether they have stock, nice stock, or whether they are sessile is the issue. Again, the difference between 2 and 3 based on the lowest filling pressure. 2 is definitely now here giving a filling problem. And finally,
Mm.
4 and 5 based on the distortion of the serosa. As you can see here, 4 is not distorting serosa at all. It is not jetting. It is hidden in the myometrium, whereas 5 is showing itself by distorting the serosa. So this is a
yes.
subclassification. Okay. And further going down under C,
See, sir, it no longer includes any AUB which is associated with pharmacological agents that impair the blood coagulations, which are now included in AUBI.
yeah, obviously,
And
because now whenever we give drug, it is iatrogenic. So it is not a problem of the patient. We gave the drug and that's why she had a problem, right?
in O category, the diagnostic threshold has been changed based on the revisions in the FIGO System 1, and it does not include ovulatory disorders which are associated with the drugs known or suspected to interfere with ovulation.
Again, they are
Again, this will be
because of
kind
the
of the
external
category
factor.
of AUBI.
Correct.
So now I will now include AUB, which is associated with all iatrogenic drugs processes, including the use of pharmacological agents used for anticoagulation and
Yeah,
those thought to interfere with ovulation.
whatever was thrown out from C and O, they have been now included in this.
Then
Yeah.
N is not otherwise classified. They have just changed the name of the category.
So, but they are now trying to new things like niche, erythemous seal, and all those things. Even infection was totally missing out from this classification. So they are now including not otherwise classified
From
chronic endometritis,
AV
arterial
malformation.
malformation. So we had two cases. I remember clearly when I was in Manipal. She had a lot of menorrhagia, and once we almost took a decision to do hysterectomy, but we avoided that because she was not at married or she wanted to conceive. Then she conceived, she delivered, but after that, again, she came with AV malformation and she insisted this time to remove the uterus, and we had removed the uterus after she had one child. Then, of course, myometrial hypertrophy, it is not a classical fibroid, but it is a hypertrophy that also sometimes need our attention. Now, let's go. ruling out one by one, which you have already done. So let's not waste our time. So going by the characteristics, if I talk about symptoms, in polyp, what symptoms you will have?
Intermenstrual bleeding, and maybe the patients of polyp will come with infertility
Yeah,
issues also.
adenomyosis,
Adenomyosis patient will have heavy menstrual bleeding, and dysmenorrhea will be present.
leiomyoma,
In leiomyoma also, sir, there will be history of heavy menstrual bleeding and
same thing. So
dysmenorrhea.
they are almost like cousins, isn't it?
Yes.
Whereas in malignancy,
And in
those,
malignancy, there will be history of postcoital bleeding or post menstrual bleeding, intermenstrual bleeding, and unscheduled bleeding will also can also be present.
postmenopausal bleeding. Yes. Okay. As far as the signs, polyp,
Signs of polyps are like on speculum examination, we can see the polyp could be coming extruding from the cervical os. We can see a parasos in such cases,
yes.
and the uterus will be of normal size. In adenomyosis, uterus will be
And that's
regularly
the main
enlarged,
difference
and it will
between
be
polyp and the fibroid. In fibroid, uterus obviously will be irregular, and in adenomyosis, it is increased in size, isn't it?
regular. Yes, sir. It will be
But
a
it is
regularly
regularly.
enlarged firm
Yes.
uterus. In leiomyoma, it will be an irregularly enlarged firm uterus. And in malignancy, it will be an enlarged, but this time the consistency will be a hard uterus. Then
Ultrasound.
on ultrasound, sir, we will see thick endometrium. And if we do saline infusion sonography, then we can see an echogenic mass. In adenomyosis, we will
We
see
just
all the features
elaborated
of
those
the
categories. Okay,
yes.
let's not elaborate again.
And in leiomyoma, we will see well-defined spherical hypoechoic areas. And in malignancy, we will see thickened endometrium with irregular endometrial lining.
Good. So this is very clear. This table will make helps you to do the differential diagnosis, ruling out one by one. So again, going by the symptoms in coagulopathy,
In symptoms of coagulopathy, there will be family history of and bleeding disorders present, and she might also give history of heavy bleeding before, and there is puberty menorrhagia. She will most likely come with pubertal menorrhagia. In ovulatory dysfunction, it will be amenorrhea followed by unpredictable and heavy menstrual bleeding. In endometrium, again, it will be predictable but and cyclical menstrual bleeding. And iatrogenic also, it will be unscheduled bleeding.
yeah, it depends upon when she stops the tablets, and in sometimes she might have endometritis in case of IUCDs, so it will be unscheduled bleeding. Yeah, signs wise, coagulopathy will have normal uterus.
Sir,
That
signs, yes, sir, normal uterus, and she may also give history of any easy bruisability or any history of petechiae before.
you yourself can
In
see that.
Yes, sir. And in ovulatory dysfunction, we will see signs of PCOD, like maybe features of hirsutism or can be present, and oligomenorrhea we will find.
Correct.
In endometrial, it will be normal uterus. In iatrogenic also, it will be normal uterus. On ultrasound features and coagulopathy, there will be normal uterus. Sometimes cyst can be present. In ovulatory dysfunction, thick endometrium with PCO pattern in the
Yeah,
ovaries can be
classical
seen.
PCO pattern. Nobody can mistake that.
In endometrial, it will be a normal uterus, and in iatrogenic, normal findings with thick endometrium can be seen.
Okay, so now there is a fashionable way of putting the notation, like we put gravida, para, G1, P2, and all that. So they want to put a AUB in also a stylish way. What is that stylish way? Suppose this is the
Sir,
patient. Yeah,
if there is a formula, sir, AUB, then all the palm coin we will classify, and like if in this patient, the patient is disordered ovulation and type 2 leiomyoma is there. So that will leiomyoma will get 1 score and ovulation will get 1 score. And we can also classify in brackets if it is an intramural or subserosal or submucosal fibroid. And we can
yes.
also give an abbreviated description that will be AUB, LSM. SM is again submucous, comma, ovulation.
Yeah, this looks very, stylish, isn't it? Okay. And also there is a matrix which you can tick in the OPD, and so that it is so obvious to you. Okay, let's continue with the examination.
This patient is conscious, oriented, and cooperative for examination. She is
Yeah, here I
moderately
have a
bent. Her
comment. Many examiners object, about this conscious and oriented. That is common in medicine, but in OBG, most of the patients that we come have consistent orientation, but you can always say cooperative patient. Okay, good.
Yes. And her BMI was 29. It was in the overweight category.
Yes, that's
Then
where
pallor was absent.
yeah, that's where we were just telling other time yesterday that that corpus cancer syndrome. She has got obesity, hypertension, diabetes.
Yes, sir.
Yeah.
And pallor was present, but there was no icterus, cyanosis, edema, or lymphadenopathy seen. On vital examination, her pulse rate was 82 beats per minute, and BP
Breast,
was recorded to be 130 by 80. And
yes.
this thing, breast and thyroid examination were within the normal limits.
Yeah,
Cardiovascular system.
you have to specify. You cannot simply say breast is normal. What have you looked for in breast? You should say that.
So breast, both bilateral breast was soft. No lumps were palpable.
Yes, very
No
good. Why
signs
is
of
it
breast
important?
malignancy were seen.
Not only
So because
malignancy,
of the
not only
so we can
malignancy.
also look for secretion. Like if she has come with
Okay.
complaints of amenorrhea or anything, then
Yeah, so
galactorrhea we can see for.
hyperprolactinemia will have some secretion, so that will give to anovulation. Anything else? One more.
Mm.
Benign condition,
Sir,
which is
if
very
like
common.
sexual character, in case of
No.
amenorrhea only, if her secondary sexual
Okay,
characters are
that's
not
fine.
developed.
That's good. That is also a very important point. One more, one more. This is how it exam goes. The examiner has something in the mind. He will till it comes out. He'll keep on saying one more, one more, one more. You have already told three, four conditions, but the commonest condition. See, what is your diagnosis? First diagnosis, provisional diagnosis in this case.
Sir, AUBL most probably
Fibroid,
benign.
isn't it? So if there is
Yes,
fibroid in
sir.
the uterus, you can also have something else in
Yeah,
breast.
yes, sir. A fibroadenoma could be there,
Correct.
like a with breast
Fibroadenosis and
mass.
fibroids are very common and coexisting. In fact, in the examination, you will get a question. What are the coexisting lesions if a patient has fibroid? One is this. One is fibroadenosis of the breast. What else? Hello, are you there?
Yes, sir. Yes, sir. I'm there,
Okay, okay.
sir.
So you are thinking. Yeah, one is fibroadenosis of the breast, that is outside the pelvis. Anyway, inside the pelvis, you can think of there are three things only coexisting. They are close cousins. What are they? Who are the close cousins of fibroid? What is fibroid due to? If I go to a little bit of theory, there are so many
Sir, it's
etiological factors, but one common factor.
sir, like smooth muscle. Basically, it is a benign tumor of the smooth muscles of the uterus,
True. It is due
myometrium,
to
sir.
what is the manure?
Sir, estrogen and like now progesterone is also proven,
Yes,
but
of course. Now
estrogen
progesterone is
mostly.
also blood, but mostly it is estrogen. So it's a hyperestrogenic state. So you have to simply think of what
Yes,
are the other conditions which are supported by estrogen and also maybe sometimes progesterone. So they will coexist, obviously. This is the clue.
sir.
Endometriosis,
And
adenomyosis, endometrial hyperplasia, endometrial cancer. Okay,
yes, sir.
so they all are
Yes.
supported by hyperestrogenic state. So this is a very simple question. Thank God I asked this question just now. So this is a very common
Mm.
question. If there is fibroid, you have to always simultaneously think. See ultimately, as I told you in the beginning of the class yesterday, there are only four conditions in gynecology, right? So you have to keep thinking that in a permutation combination, sometimes you have to tell somebody first, somebody second, somebody third. So if fibroid is first, then you have to, tell adenomyosis, endometriosis, endometrial hyperplasia, endometrial cancer. And outside the pelvis, fibroadenosis. And if there can be breast cancer also. So these are coexisting conditions, and common factor behind all of them is hyperestrogenic state. Similarly,
Yes, sir.
you can't simply say thyroid normal. This particular patient actually has got hypothyroidism. So you must say whether thyroid is enlarged or not enlarged. Okay. And cardiovascular system
Yes.
S1, S2 is present. They better be present. So you don't have to really tell.
Yes.
It's not a cardiologic case, but you must say there is no added murmur because that is a part of the preoperative evaluation, right? Basically. And
Yes, sir.
respiratory system is very important. You have written here no added sounds. What are the added sounds possible in a case of fibroid?
Sir, sir, if the patient is having very severe menstrual bleeding, she could have anemia and she could like going into failure. So that time, like crepitations, while
Yeah,
basilar
that's
creps
one
would be
thing.
present,
Yeah,
sir.
that is one thing. Anything else can happen? Can there be some collection of fluid? What do you call that
Yes, sir.
condition?
Pleural,
Yes,
sir. Pleural effusion, like this thing,
Meek
it will
syndrome,
be there. So
something.
they,
Yeah, there can
yes,
be
sir. Meek
something like a
syndrome.
Meek syndrome. Okay, so that also will affect our
Yes, sir.
respiratory system. Good. Coming to abdominal examination,
Sir, on inspection, the previous transverse scar was present. There was no other dilated veins or sinuses seen. Obesity was present. On
previous
palpation, a
scar
mass was
usually
felt.
should be transverse or vertical.
Sir, what, sir?
Yeah,
But this
vertical.
patient
Usually
had a
because
transverse scar.
see, this is the operation
Hmm.
done in the immediate post natal period, maybe day two usually, and the uterus is quite high in the abdomen. And if you put a transverse incision, though we say transverse incision is a better incision for as far as healing is concerned, it is always better to put a longitudinal incision in the midline, and so that you can put a small incision initially, and it can be easily extended upwards or downwards. Okay. It doesn't matter. Anyway,
Yes,
whatever
sir.
is there, you have told. Obesity is present, then okay, next. Next is very,
Yes,
very
sir.
important.
On palpation, sir, a mass is felt arising from the pelvis in the midline with a size corresponding to an 18-week gravid uterus. It is firm in consistency and it has well-defined round borders and smooth surfaces. But the lower border of the mass cannot be made out separately and transversely it is mobile, sir. And
Yeah.
on percussion, dull note is present over the mass.
Yeah, I think you have given the full description, which is fitting properly into fibroid. As you correctly have written here, mass arising from pelvis. But some professors, some examiners expect, but I prefer the way you have presented that, when you say size corresponding 18 weeks, immediately we all obstetricians are tuned to what should be the height of the uterus. But some examiners insist on centimeters. In Manipal, one of the examiners always asks in centimeters. So you should know both. Okay. You can say 18-week
Yes,
gravid
sir.
uterus also. You can say it is so many centimeters. And you have written it is mass arising from pelvis. The proof of that is lower border is not made out. Sometimes if it is a single
Yes, sir.
fibroid, it can be smooth borders. But usually fibroids are
It will
multiple
be
in number.
irregular.
Yeah, multiple in number.
Yes, sir.
Usual habit. They are and they belong to different generations also. One is 2-year old, one is 5-year old, one is 6-year old. As a result, the borders are irregular, surface is also irregular. But in a given, in
Irregular.
your case, probably there is a single fibroid, maybe intramural fibroid.
Yes,
So
sir.
there may be rounded borders and a smooth surface. Okay, but typical of fibroid is irregularity. And obviously there will be dull
Yes.
note on the mass. So you are trying to differentiate whether it's a, there are only two conditions in gynecology as far as mass is concerned mostly. One is uterine mass, other one is ovarian mass. So
Very
ovarian mass, if
masses.
it is usually cystic, if it is a cystic, there
Yes,
will
sir.
be dull note actually again if it is so big and in the center because it will push the intestines to the sides. Whereas if
Sides.
there is
Yes, sir.
ascites, if the ascites is there, you will have dull note in the sides or in the flanks
Sides.
and intestines will be in the center. So this is the basic difference. So we have to corroborate the abdominal findings with the per speculum and per vaginal examination. So what is your per speculum finding?
On perspectivum examination, the cervix was healthy, it was pushed down, and a slit-like orifice was seen. There was no polyp erosion or mass seen arising from the cervix.
Yeah, very good. But you have committed yourself saying that cervix is pushed down. In which type of fibroid, if it is fibroid, it is pushed down, and in which fibroid it is actually taken up.
Sir, usually in the anterior wall like fibroids, it will be pushed towards down, and in posterior wall, it will be pushed up. As well as also if there is a history of any previous cesareans, and then it can be like pulled up cervix in
That's
those
one thing.
patients.
Which one more category of fibroid where it is almost like a effaced cervix, very short cervix. It is hitched under the symbol. Which fibroid will give rise to that? I agree with the answers what you
Cervix,
gave already.
Cervical fibroid also,
Very
sir.
good. Very good. When there is a central cervical fibroid, so it is almost like head coming down, right? So cervix
Mm.
is almost
Yes, sir.
effaced, and you will see a very, very tiny cervix hitched under the symphysis pubis. Rest of the answer is correct. And orifice is slit because she's a Paris lady. No polyps. That's a good
Yes,
description. No erosion, and no mass is seen coming out of it. Sometimes it can be cervical fibroid which is coming jutting outside, or could be a fibroid polyp also. When you do a per
yes.
speculum examination, of course, you have written here cervix is healthy, but at this juncture only, you should finish it off one more, which is not exactly examination. It could be an investigation. What is that?
So pap smear we can take at that moment only for the
Very
patient.
good.
Or
Very good. Because if you don't do that, and if you go for a PV, then you have to call the patient one more time. Pap smear should be done
yes,
when
sir.
you are not using any lubrication or any other,
Lubricant.
right? So, and this is an opportunity for
Yes,
you to rule the cervical cancer. Apparently healthy, but you can't say. And if you want, you
yes,
believe in colposcopy, you can do that. And if there's an obvious lesion found on the cervix, you can take a biopsy at this juncture itself. Very good. Let's move on to
yes.
vaginal finding.
And in this, sir, uterus was bulky again up to 18 week size and transmitted
Asti,
mobility was present. Yes, sir.
why I have put bulky in red color? I made red color. I just took you off. Why I have made it red color? Meaning I am finding fault with that.
We can write, sir, uterus enlarged up to in 18 week size. Like
See,
what?
you have to be very, very careful. I'm just telling. I'm happy actually you made this mistake here because we can learn
Yes,
together for others. See,
yes, sir.
18 weeks size uterus is not bulky uterus. You see, so you should know the exact size of the uterus. For that, you should do 2,468 PVs. How many?
So many PVs.
Yeah, you must do many PVs because nobody knows what is normal size of the uterus. We simply say uterus is normal size because it is not bulky. Okay.
Yes,
So
sir.
by doing many PVs, as I said, you will know what is the normal size. When you say bulky, it is not normal,
Yes, sir.
but it is not
It is up
so big as to come out of the pelvis, right?
up to 12
See,
weeks, like it.
yeah.
Mm.
See, you are saying abdominal, it is 18 weeks, which means it is felt abdominally, and you are saying bulky. These two things don't go together. Okay.
Yes, sir.
And remember this very
Mm.
clearly. It's good that you made a mistake here, but you should remember
Yes, sir.
very clearly that bulky uterus is slightly bigger than the normal uterus. And you see, which is the earliest we can diagnose pregnancy clinically?
12 weeks, sir. Like,
8 weeks. 8 weeks by
mm.
pervaginal examination. Okay. So 8 weeks is more
Yes,
than bulky already. And 12 weeks is just at the, symphysis pubis we can feel. And 18 weeks clearly,
yes, sir.
clearly above it. So
Yes, sir.
you simply say uterus is same enlargement, what I felt from the abdomen, I am feeling. Uterus is enlarged. And
Yes,
another thing is you have written one more mistake I have found here, which I have not highlighted as red. You have written bilateral fornices are free. That is also slightly not acceptable because, again, when we say uterus is 8 weeks or 10 weeks or 12 weeks, it will occupy the entire pelvis and fornices will be full. That's what we
shallow.
say, if you
Yes,
remember. Right here it is 18 weeks, but you can still say, you can still justify your answer by saying this could be a fundal fibroid.
yes, sir.
So that, did you think of that answer?
Yes, sir. Because
Good. Good.
actually,
If you have thought of it, it is very good. So you can say it is not like a uniform enlargement as happens in the pregnancy, right? So it could be a fundal fibroid. That's why fornices are free here. Instead of saying bilateral fornices, you can simply say both fornices are free. Okay. But all the PGs
yes,
have a habit across India saying bilateral fornices are free, bilateral breasts are normal. Instead of saying that both breasts are normal, both fornices are free. Okay. So now,
yes,
do you want to change your diagnosis after examination? See, in gynecology, at all levels, we have to make diagnosis at the history level, at the examination level, and after the investigation. Any change here, or if you agree with that, we'll just move on. Your
No,
list
sir, it
remains
is
the
the
same.
same.
Okay, very good.
Yes,
So you have put it as 51-year-old, para 3, living 3, previous NVD. Again, I've just and sterilized with AUBL and hypothyroidism diabetes. So I've just modified it as 51-year-old P33 who had bilateral tubal ligation instead of saying sterilization after 3 normal
yes, sir.
deliveries and instead of vaginal
Hmm.
deliveries, having AUBL with associated with comorbidities like obesity, hypothyroidism, and diabetes. So both are all right. Okay. So
Yes,
now
sir.
I'll come to the
Yes, sir.
investigations quickly. This clearly shows that
Yes, sir.
she has got a real problem
She
on
has.
hand. But I want you to
Yes,
comment
sir.
specifically on the last one, LDH. Why did you do LDH?
Sir, because LDH, sir, to rule out leiomyosarcoma, if there is
Very
a
good.
malignant
Very good.
this,
Nowadays, it has
that's why we,
become a routine investigation in all cases of fibroid, especially if you plan to do a laparoscopic myomectomy and you want to do morcellization, then there is a chance of spread if it is by chance sarcoma. So it is mandatory to do LDH and it is normal. I have just highlighted abnormals are red. TSH is important because anesthetist will not give anesthesia if it
yes,
is more than, let's say, each hospital varies. In our hospital, I think they don't give if it is more than 10, if I remember correctly, 10 or 5.
sir,
So,
above 5 also they will ask
yeah,
clearance.
yeah, that's fine. It depends upon anesthetist. Hemoglobin is low. That
Yes,
means we should not take up for surgery unless it is 10 grams. And we should also
8
keep
grams.
1 or 2 pints of ready because myomectomy, if you are planning to do,
Yes,
then it will go. If you are doing hysterectomy also, sometimes there can be extra bleeding. And
bleeding.
of
Yes,
course,
sir.
diabetes should be under control so that we can avoid the infection. Ultrasound is almost corresponding, your findings are there, but important thing, I'm happy that you have looked for endometrial thickness which is well within normal
Hmm.
limit, especially for a premenopausal
Yes,
lady.
sir.
So we don't have to
Yes, sir.
really
Yes,
worry, but it is better we still do a endometrial sampling and rule out
yes,
endometrial
sir.
hyperplasia or cancer. Bilateral, instead of saying
Before
bilateral ovaries are
proceeding.
visualized, both the ovaries are not visualized. But instead of saying not visualized, because it shows that fibroid is so big, it is masking. If a careful
Yes,
exam,
sir.
ultrasound examination can show no free fluid. That means there is no possibility of any other problems.
PID.
No tenderness means it is not infected one yet, or there is no
Yes, sir.
torsion or anything like that. So
Yes, sir.
instead of putting it this way randomly, I would put it in the examination, especially in the theory exam. Investigations done to
Yes, sir.
diagnose, that is all these things. In fact, in every single patient, even though she's 51, this particular patient, it may not be
Yes, sir.
relevant, but we must do a pregnancy test in a younger patients. So heavy bleeding can
Yes,
be an abortion or irregular bleeding can be a problem, or she can be having a trophoblastic disease and all those things. Ultrasound, we have told, if there's a doubt, you can go for MRI. Nowadays, most of the people in the practice, they do all the three: ultrasound, CT, MRI. Okay, that is not required. And preoperatively, these things are done just to see.
yes,
Okay, and as you said, you are talking about sonohistography, which can be beautifully seen here, and ultrasound.
yes.
So after investigation, what's your diagnosis now? Final diagnosis?
Sir, it is that only, sir. She is
It is.
a
Yeah,
51
it's a
year
case
old.
of, yeah. It is fibroid only, right? So it is
Yes,
a
sir. It is
fibroid.
fibroid uterus.
Yeah. Now let us quickly, in the next 10 minutes that we have, or 7 minutes, we will discuss the management. So how do you propose to manage this patient? You just tell me the outline.
So first of all, we need to give the patient symptomatic treatment for
Very good.
heavy menstrual bleeding.
Done.
Then,
Build up our
then
hemoglobin.
we
Yes, all those things. General management,
yes,
let us keep it aside. Let us talk specific management for a case of fibroid at 51-year-old
for
women.
her, sir, the best option will be to go ahead with hysterectomy only
Yeah, so this
because
particular case is
she
actually very, very easy, that there is no doubt,
yes,
because she has completed family also. She is 51-year-old also. She has got a big fibroid also. If not menorrhagia, she can have pressure symptoms. On top of that, she has got menorrhagia, and medical management for a big fibroids is not going to be that useful and all that. Probably in this particular case, it is almost straightforward. Okay,
yes, sir.
but if the patient says, I am young, I am 51-year-old, do you have anything other than what is your if is what is your surgical management? You said hysterectomy. Is it
For this
hysterectomy or
patient,
myomectomy?
sir, for this specific patient, I said hysterectomy.
Very
Otherwise, we
good.
will
I
go
agree
ahead
with
with
you. I
myomectomy.
agree with you. I
Huh.
agree with you instead of doing myomectomy because that is very a big fibroid and she will have a lot of bleeding. And if you leave behind the uterus, unnecessarily, because this patient, when they have this kind of situation, they will have a late menopause also. It's like whether egg came first or hen came first. Because of late menopause, they can develop fibroids, and patients having fibroids usually have late menopause. So if you simply do myomectomy and come off today, after 3 4 years, she may come back with another myoma also. So
Yes, sir.
this patient, but if there is a patient who says, I don't want hysterectomy, tell me something else. In fact, I had
Sir,
a
if
patient like
she
that.
doesn't want,
She didn't want hysterectomy. So what are your options?
sir, if she doesn't want to go ahead with surgical management, then we can offer her medical management, but it is like we
Quick
can
medical
offer her
management.
GnRH agonist.
Yeah,
So there is
I am happy.
GnRH
I'm
agonists.
very happy that you talked about GnRH first because that is the definitive or better management of all the medical management, and especially in this age group. Sometimes what we have seen is when you stop the bleeding with other routine managements, which I'm not going into right now. As I said, tranexamic acid can be given, other things can be given. GnRH analog will also not only stop the bleeding eventually, but mostly it will try to control the further growth and it will little bit shrink the fibroid also. And for all you know, she may have little bit, we are pushing her into menopause. And once she attains menopause, then there will be a further decrease in the fibroids, isn't it? So fibroids is the
Yes, sir.
slowest growing tumor. It will take 1 centimeter per year. Same fashion, it will regress also. So you can counsel the patient that way. And but what are the side effects of GnRH analog and how many doses you can give?
Sir, like only 3 to 5 injections, like monthly, if we are giving 3 to 5 maximum doses we can give. Why? Because she will have the hypoestrogenic symptoms she will have. She will have
Very good.
vaginal
She is in the
dryness, hot
yeah, very
flushes,
very good. I'm very happy that you thought of it. She's in the
osteoporosis.
premenopausal age group, so we are pushing her into osteoporosis. But good thing is that it is reversible. The moment you stop it, she won't have that much of a
Yes, sir.
problem. Okay, so I agree with you. Any other options? Suppose she says, if I don't want to take this GnRH analysis because many women they are scared of taking any hormone. What are the other options?
Sir,
Non-surgical and
then,
non-medical.
sir, we can give that levonorgestrel IUCD also, which is available. That will also
Provided
provide symptomatic relief,
provided her cavity is not
distorted.
very good. That is very important. Otherwise, she will come back within no time saying that it fell off. So you have to make sure that the cavity is not distorted. I totally agree with you. LNG IUS will not only regress little bit of the fibroid, and it will stop her symptoms. That is most important. Her symptoms, she is
Yes,
distressed
sir.
with the symptoms, and
Yes,
slowly
sir.
the fibroid may become smaller. All right. And she may get into menopause. See, next 5 years, she will not have any symptoms. She will be 56. By 56, she will attain menopause and she will totally get rid of that.
Yes,
Any other.
sir. Otherwise, in
So,
medical
as you
treatment,
correctly said,
we
tranexamic
can,
acid and progesterone for symptom control, myomectomy if the
yes,
patient is younger, GnRH analog, you already said, LNGIS, you said. Of course, okay, I just
uterine
showed
art,
it. Yeah, I'm sure you knew that.
sir. Yes, sir. Uterine artery embolization also we can offer, sir.
Yeah. In
But
fact, I
it is
offered
an
the same
expensive
thing.
procedure.
I offered the same thing to the patient because patient already had read and come. She said, I want to go for UAE, and in Manipal they do it. And definitely it will also shrink the fibroid by 50%. Most of the things which shrink the fibroids are 50% only. But again, hoping
Yes, sir.
that by that time she will attain menopause and she won't require a hysterectomy. So you